This is Matejka presenting my quality improvement project, Implementing Patient-Reported Outcomes. I'd like to thank everyone for their input in this project, especially Dr. Valier for really shaping this project. It changed several times, so thank you for all of your help in getting it to the final product we have today. So to start this quality improvement project, we had to identify the main problem. This case, a large percentage of athletic trainers still do not use patient-reported outcomes. One study found that only 26% of athletic trainers use them. So see this big portion of athletic trainers who do not use any form of outcome assessment. Athletic trainers more commonly use clinician-based assessments. So think your manual muscle testing, special tests. These give us a lot of information about the physical injury, but they don't always give us a great insight into the patient's view of the injury. So the actual disability or impairments, which we'll talk about, aren't always seen without patient-reported outcomes. Patient-reported outcomes can measure the patient's experience, their values after medical treatments, interventions, practices, rehab, pretty much all the services that athletic trainers provide. They can also give insight into other possibly affected domains. Most notably, a lot of studies have found that depression is very common among athletes following a sports injury. So that isn't even being accounted for when you're just doing a special test or you're just looking for manual muscle testing. Obviously, we're not getting whether or not the athlete has depression or any other domains that could be affected. So, of course, this is going to negatively affect the patient's health-related quality of life. So when we look at disablement models, these really come into play when we're using patient-reported outcomes. We use these models as a way to organize clinical practice decisions. They're really a critical piece to practicing evidence-based medicine. So the model that we're looking at here is the International Classification of Functioning, Disability, and Health. And we look here at the top, we have the health conditions or the disease, disorder that we're looking at. So most of the time for us, it's going to be an injury. The body structure and function, we're looking at impairment. So that's the part that athletic trainers are usually very in tune with. Limitations or activities, again, we're doing a pretty good job of this. How do we restrict certain activities based on the body structure or the type of impairment? And then participation restriction kind of goes along with that. And then we have to include environmental factors and personal factors. And this is where pros come into play. We have to look at impairment versus disability because they're not the same. Disability is an umbrella term that is used to describe impairments, activity limitations, and participation restrictions. So it includes all of those. These can be measured objectively using questionnaires. Impairments are the loss or reduced capacity of a specific physiological ability, such as strength or range of motion. So again, we're usually good at identifying a specific impairment rather than maybe some of the other disability that the patient's encountering, again with the example of depression. So for this project, our baseline assessment, looking at a very specific local setting. It's a small Division III university with 8 athletic trainers. One is administrative and not practicing in a clinical capacity. We have 3 dual role clinicians who also serve as professors and instructors. We have 1 strictly clinical athletic trainer, so no teaching, and 3 graduate assistants. Now, all of these people have multiple sports. Sometimes their coverage overlaps, so they may have a fall sport, finishing up, and a winter sport. And collectively, there is no current patient-reported outcome use, either individually and certainly not as a group. So looking at this visually, all the different components that could have been factors of why pros aren't used. We found education, so lack of formal education on pros. There's also this fact that just people, new graduate assistants annually, every year there's turnover, and people work autonomously for sports coverage, but there's no common pro selected, because there is going to be overlap, especially with the graduate assistants filling in for treatment while the other athletic trainers are teaching classes. Environment, again, small school, limited budget, and then materials come into play. Computers versus electronic. That could be a factor of why we don't use pros. It's certainly easier to use the computers rather than, filing paper and whatnot. So when we looked at this, we found out of all of these things, education is probably going to be our best bet to be able to change and hopefully implement the use of pros. So with that, the overreaching goal is eventually to collect goals as an entire staff. But for this project, we wanted to create and deliver educational modules, educating athletic trainers on healthcare outcomes, and basically just to introduce the idea of patient-reported outcomes and get a feel for how that would be received and if people were going to be positive about implementing their use, and going from there to hopefully get to that overreaching goal of using pros as a staff. So with this, we have our plan, do, study, act cycle. The plan, again, to implement a strategy to provide education to the athletic trainers. So to do that, we made a pre-module survey, and that just gathered information that this will all be displayed visually at the end. But what we wanted to get from the pre-survey was an idea of the athletic trainers' pre-existing knowledge and attitudes towards pros. So there'll be questions, have you heard of pros before? If yes, where, undergraduate, graduate level, through your work experience. So it's just to get an idea of what they knew beforehand. We also made 2 educational modules. One was just a basic information on pros. The second one was more clinical application. So how can we implement? What types of strategies can we employ here? And then afterwards, the athletic trainers were asked to take a post-survey after watching the modules to see if their attitudes or knowledge had changed. And then this one was a little different. We asked them how effective or efficient they thought the modules were in presenting information about pros. So again, we could kind of see how that changed after watching the modules. Then we evaluated the completion rate, which we were happy that we had 100%. All the athletic trainers took both surveys and watched both modules. And then again, to see how the knowledge either increased or decreased. And again, the ease of use of the modules, or how efficient the athletic trainers felt that the modules were. And then the last step, the ACT portion here of the cycle. Hopefully we're going to implement the module use. Again, our graduate assistants turnover every year. So every year we have new graduate assistants. So we're thinking if the modules were effective, that we can use this every year as annual training. So then everyone can have a uniformed education on pros and how we're planning to use them at this specific local setting. And then if we found that the athletic trainers did not think that the modules were efficient, or there were too many questions afterwards, or just not an effective means to deliver, then we would consider other options. So maybe in-person training, perhaps a more formal presentation where they could ask more questions. So that was going to be our cycle here. This is a new process, so This is a new process flow chart rather than what we have because we don't have any current pro use. So to start, we had a recruitment or an introduction meeting. I just gave a very brief, I didn't want to influence them, so I gave a very brief, will you participate kind of spiel, and then moved to distributing the modules via email. That way the athletic trainers could take them at their convenience. The athletic trainers took the surveys and watched the modules, and if there was negative feedback, again indicating that the electronic training was insufficient, we would consider maybe in-person training. If it was positive, then we would continue using the electronic modules as annual training for everybody, and especially for those new hires. Just to look at the data more visually, the first question we asked was, have you heard of patient-reported outcomes? And I was actually surprised by this. A majority of the athletic trainers had heard of them, but still a large portion had not, still a significant portion there. Looking at their first exposures, most of the athletic trainers had heard of them during their undergraduate program, equally through clinical practice or their work site, and then 20% at the graduate or post-professional program. So still 20% of people, athletic trainers still aren't learning about pros until the graduate level. So looking at their attitudes about pros before viewing the modules, a large portion of the athletic trainers were had neutral feelings towards pros, and the other portion were felt positive about them. So that's good. After viewing the modules, I was pretty happy with these results. Everybody, 100%, they were either positive or felt very positively about it. So hopefully viewing the modules maybe answered some questions or cleared things up so that they, those neutral feelings went away. Previous experience using pros, large portion, no experience. So majority here have no experience. The smallest part, yes, they have used it, but they had neutral feelings. And then the small portion, 25%, have used it, and there was positive experience. So the good thing is no one said that it was a negative experience. When we asked them if they were familiar with potential benefits of using pros, most pretty unfamiliar. So unfamiliar and somewhat unfamiliar is dominating there, and somewhat familiar. So no one was very confident with their familiarity, and potential barriers, same results there. Before the modules, we asked them to click any of the benefits that they could see to using pros. So here we have enhancing communication and increased patient satisfaction were the highest. And afterwards, you can see it's really nice that they, included help direct plan of care, because I think that one kind of flies under the radar a little bit. But then all of the other three, everyone agreed that these could all be benefits. So it definitely opened people's eyes to some of the other benefits that could come from pros. Same format with barriers here. Big one, not surprised, is that it's too time consuming to use. And that kind of stayed higher than I would have liked, but a lot of the other areas went down. Post-measurement, 100% of the athletic trainers completed the modules and the surveys, so we're really happy with that portion. A majority of the athletic trainers did not have any experience using pros, which we already talked about. So lack of experience in education is probably going to be the biggest challenge for us implementing pros in this setting. But it will also help focus the training, because we know that the athletic trainers don't have education experience. So that'll be something that we can really focus on. After the modules, all the athletic trainers had positive feelings towards pros, so that's very encouraging for introducing them and implementing them in a more uniformed manner. Another crucial lesson from this project was that the athletic trainers deemed the modules effective. So the electronic delivery is a good format for annual training. So this is a huge step in moving forward to allow us to implement pros, because we can have everyone educated in the same way, and then we can move forward in creating a procedure. Lastly, some of the strategies for implementation that might be best suited for this local setting based on the results. We could use one universal outcome, so maybe just an overall health-related quality of life outcome. We could also try selecting regional pros for each body part. Some examples might be the lower extremity functional scale, or LEFS. That can be used for any lower body injury. So we can even consolidate them, having a lower extremity pro and an upper extremity pro. Something simple that all the athletic trainers can learn and everyone knows how to use it. Or we can start collecting pros with just a few teams, kind of use these as our pilot studies, and then once everyone becomes familiar with them, then we can move on to implementing them universally with every single patient that walks into the facility. So in conclusion, the results of this project, we saw that the educational modules provided athletic trainers in the local setting with improved familiarity with both benefits and barriers of pros. I think that's half the battle sometimes, is letting people know that those barriers sometimes aren't really reality, that they're perceived barriers. Athletic trainers also felt positively about implementing some sort of pro into clinical practice, so having that positive attitude is going to be huge in moving forward. I don't think we're going to have anyone having negative thoughts about implementing them, so that will also be a critical element in moving forward with a new idea here. And that this could lead to the eventual creation of a procedure so that the pros can be used by the entire staff.